bricks on a screen, healthcare in between. Physics, art, and math guide us down this path. Historical tales come alive, where science and stories dive. Blended facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix. Need bridge got the fix. Complex subjects make
right
clear
now
every episode
in ways that we actually acquire the knowledge
leads the way.
and ways that make me more efficient.
In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Here is a small housekeeping note. We have upcoming this Saturday, Minority Health Institute 7th Annual Summit is going to be conducted by Dr. Richard Allen Williams. He is an icon and legend. He is a founder of Association of Black Cardiologists. And then he does every year this Minority Health Institute Summit. Dr. Diana Ramos, the California Surgeon General, is going to be speaker. So and the other distinguished speakers are going to be there. Please try to attend if you are in Los Angeles area or any other place.
My guest, Bogi Eliasen, is coming from joining from Copenhagen, but he is traveling. He travels around the world. He is now in Argentina. But I tell you, the most important thing is health is, in the United States, we are still debating health is a human right, is a privilege. It's no question. Health must be human right. That's the first thing. We have to protect humans, not the robots, not the aliens. We have to protect ourselves. That is the most important. Health is a human right, and he is a champion for that. He is a director for the Movement Health Organization, an organization dedicated to advancing the healthcare around the world with the digital health and advancing all the things they do around the world. Around the world, they do quite a bit of work. So let me bring my guest, Bogi Eliasen. I hope I'm saying his name right. Let me bring him onto the table. Mr. Bogi Eliasen, welcome to the MedBix Webcast, sir.
Thank you so much. Thank you.
So tell us a little bit about your background, if you don't mind. And you have excellent credentials. You are from World Health Organization. You did everything. So tell us a little bit. Give a brief introduction about you.
Yes. So I am from the very tiny, remote Faroe Islands, somewhere in between Iceland and Norway. It has now some 55,000 inhabitants. When I lived there, it was like 45,000. My background is in political science and international law, and my plan when I went to university was to go into politics. I still do some kind of politics, but just not organized in the way that we normally see that. Maybe it's more policy. And when I started working in the Foreign Office in the Faroes after graduating, it was the time when the Human Genome Project was beginning to be at its end, and Iceland started with this Decode project in Iceland, and there was a huge interest to start things in the Faroes, which then ended up being a part of what I started doing, not because I'm a political scientist, but actually because my wife, who's from Peru, is a geneticist, and then we started framing some of those things. After some years with trying to push for economics, which was the approach with the Farjan project in the Faroes, and also together with some of the leading persons in the Human Genome Project, my realization was also quite clear that if we really want to improve health, we need to, and I was looking for a place to work with that, and a friend of mine told me about the Copenhagen Institute for Future Studies, where I then contacted them and told them the future of the world, that they didn't have a health department, and volunteered to build that, which I then did, and was 11 years until March as a director, where we have built different approaches to cross-disciplinary work on health, but sustainable health by being much more preventive. And a part of that was also to initiate this Movement Health Foundation 5 years ago, specifically in the beginning, strengthen health systems in Latvia. And of course, when you begin to work with these kinds of thoughts and networks, also almost by design end up being part of some World Economic Forum and others.
Very good. So, my father is actually a small rural village doctor. He's a teacher. There's no it's a 2,000 population. At the time when I was growing up, there is no electricity. There is no running water. And my father is the only doctor who can read English. And then he was a savior for a lot of people. He was giving injections and all those things at the time, penicillin. I pretty understand. That's why he inspired me to be in the healthcare area. I did not become a doctor, but I became a very healthcare advocate, and I placed a lot of doctors in this country. Let me ask you, it's not about me, about you. So one of the things is, now let us talk about a little bit of the United States, and then we will go into the United States. We are having, health is considered as a privilege here. It is a big problem here. We are debating, is a privilege or is a right. We're still debating. It should not be a debate for a debate. And then second thing is, we have a chronic diseases are uncontrollable here. Obesity and the diabetes, hypertension and cancer is all growing up. Tell us a little bit about you made an excellent post on recently. I wanted to say just a little bit about, shed a light on the United States, American healthcare system a little bit.
Well, I think there are a couple of ways to articulate this also to get a right understanding. United States has some excellence in research and application for a part of the population, and then very many left out in it. And when we generally think of right or health as a part of society, it does require that you include some kind of risk sharing. That was the whole idea from the beginning when Bismarck went in Germany, began to work with social justice and access to health. And if you buy into that logic, that's because you believe this makes a more resilient and better society. And if we go further in and look at the external factors that you also mentioned, so I'm no expert on US, but of course you follow it as it is one of the leading, how can I say, drive for many reasons. But you could say that generally we normally conclude that only 30% of the health outcomes is driven by the health. The rest are factors around it, like education, living conditions, food, not least, which you also mentioned, exercise, sleep. Of course, we need help and it is a challenge that that we only in our Western health systems have fallen into a logic where we need to have very, very intensive help, but very late, instead of thinking earlier in that part. So there is, when you look at the US system from my side, partly there is a lot of disease-causing factors in the society, which you could work with. There's a huge inequality in who can access care than when they need it. But we see it as access of care, but the real challenge is that there is also a lack of access to a healthy life from birth for many.
Yeah, there is a lot of people who don't have access to healthcare in this country. It is a tragedy. Their argument is that we invest a lot of money in the healthcare, so we need to get the returns. A very false argument in my view. But let me ask you. That there are a lot of things that you do in the countries and around the world. Let us talk about little bit about the woman's health, maternal health, and child care. Little bit. Let us give some idea about international maternal. Very surprising, as you know, United States is the leading cause of maternal health, one of the highest number, even though such an advanced country, it is one of the highest in the among the advanced countries, maternal mortality here. So tell us a little bit about the maternal health. How do you approach the maternal health and the child care around the world in general and the countries that you are working in?
Yeah. So
If you don't mind, your video is chopping out, is not moving smooth.
okay.
Do you want to come back? Maybe just rejoin back. Yeah, that's
Uh,
yeah. Just don't move too much. Maybe that is the best way.
okay.
Yeah,
Okay.
you're in
Okay.
Argentina.
Very good.
Your hotel website, hotel
Yeah.
doesn't help you.
Yeah.
Okay, go ahead, please.
Yeah. Okay. Yes. Maternal health, we think we should see it as woman health or female health, part of that, and that area has been neglected for decades, if not always. And one part of it is, for instance, the lack we have on cancer diseases, specific female diseases that have not had the same as general diseases or male diseases. A project on maternal health, digital health in Bulgaria that we are working with, where we have scaled a solution from Finland into the Bulgarian health system. Then we are working with on underserved communities is in Peru and in South Africa that we just started on cervical cancer, which then goes into the female health than the maternal in that part. But also beginning to focus on the HPV vaccine as approach to reduce these challenges that we see in many and overwhelming evidence of this around. So specifically from my organization, these are the focuses that we have on. If you then look in your specific question on maternal health, this is an area that has been on average improved a lot over the last decades. But yes, we have pockets where we still have huge challenges. Especially in underserved communities, also in rich countries. And that is not because the health system cannot deal with it. It's because the social determinants. So people are coming very late into treatment. There is lack of trust in it. It's probably more about the trust than it's about the specific care in per se. And I think we are beginning to learn also that if we want to build health, and let me just go a little bit back on what the core is of what I work with and what we drive with movement health, is asking the question, what happens if you out a scenario where health is the most important societal pillar? Okay. We normally don't valorize health when we don't have disease. It's only when we begin to think that we need something. But it is the most precious thing that we have. One thing for the person, but for society, it's a huge loss not to have or to have avoidable disease burden, which in the Western world is caused by some of the factors that you mentioned with food and a lack of exercise and the way that we are living. So we estimate for instance, the Nordic countries that 30% of the disease burden that comes into hospitals is totally avoidable if we just applied our knowledge and the technology that we have at the right time. So when we talk about crisis in the health system, it's not about money. It's about the way we are working. So that is one side, and I know this is not that black and white in the United States, because you have differentiated and based to a large extent. But still, when you spend in Denmark 10% of GDP, in US 18, if I'm not wrong on that part, there is an obligation that this is a driver for a resilient society. Resilient seeing, because we are for treatment when you are very ill. We are not on intervention before you get, if we know that this is the right thing to do. On applying very advanced technology in volume late, instead focused on outcomes with these technologies earlier. And we call this, or we are trying to push this as you could say, a reverse part of opportunity cost, to call it cost of an action. So what are we paying or losing as a society because we are not keeping people healthy with the knowledge and the resources we actually have? And then you can ask yourself, okay, why do we have this challenge? Because we actually, on average, in health systems, we never had more personnel, we never had more funding, we never had more materials to work with, machineries in different ways. We see a health system on the verge of breakdown all over. And that's where I ask the question, are we doing the things right? No. And are we doing the right things? That's also a no. So we are focusing wrong in that part.
You did a recent post on it. Actually, you quantified that prevention is what is every dollar you spend, every $2 return or $4 return on the investment if you prevent the diseases. That's a beautiful way of putting together, quantifying the investment on the health system. You did that. In fact, that is a true in even the United States, everywhere. That is absolutely true. We postpone until the emergency room is. If you go to emergency rooms, are expensive, and then these are all a lot of them are, as you said, either preventable, and we have these same challenges. It is a sad story, because even advanced countries like United States having the same problem as the third world countries in the healthcare system. It is really tragic in this sense. We have to really remodify the entire healthcare system. As you said, prevention is the best. What about the child care? A little bit to spend on a little bit of child care. You mentioned a little bit, and tell us a little bit about in those countries, in the particularly child care in the developing countries.
So your question is on how we work with
Child health, yes,
in
correct.
developing countries.
Correct.
So, yeah, the part we have worked on, for instance, in Peru, in Cusco, we worked with getting better uptake of child vaccine, the most important thing on that part, and that is really important. But child health in general is also something you build by having more resilient communities, really having these accesses to education. So it doesn't matter what we do around the world. It's a quite clear observation that the level of education you see in the level of health in the population. So you also need to work with those parts. We as movement health, we are not focusing on the education, but we do focus on the vaccinations in order to get that to drive health for children, so they get an education in it. And I would just mention here also that in Denmark there is just initiated a program to be focusing on healthy foods in school, because even a egalitarian country like Denmark, there are still differences. And big surveys have shown that children from the poorer part of the society more often go to school without breakfast than from the of it. It's not because you need to go without food in Denmark, but by some reasons this happens. And you also can see in aggregate that there is a difference between social mobility or the lack of social mobility, and that if you don't get your foods for your body, it's hard to remain with the food for the brain. We also know this from work in so it is a focus that probably will come around really to get healthy food habits back.
In the United States, we have this vaccine debate. It's like whether the vaccines are good or bad, and then all kinds of debates are going on. How easily available these HPV vaccine for the preventive cervical cancer? I interviewed actually a couple of guests from South Africa, in fact, and they're also made, as you said, that you're doing a major initiative there. So the HPV vaccine and the other vaccines for children, where is that stands? Is it plentifully available, or is it a challenge for organizations to go into the developing countries, the low income and middle income countries? Is it easily available, or is it one of the biggest challenges in the vaccine availability?
Yeah, so we have big global organizations like Gavi that is really giving access for everybody. So the question is, what challenge here is that the trust in the population to be vaccinated is a huge challenge in many places. If it is accessible, so accessible is not necessarily that you have the logistics to get it out to everybody who should be vaccinated. Then even if you do that, you also need to have some kind of monitoring on and registering who gets vaccinated when, so you can follow up on those. I think we are seeing a huge progress. It requires a very tough push on health literacy of these different things. But for instance, just like in US, you have also seen a hesitancy in parts of Europe going in the discussion and in other countries. And it is, of course, a very easy political stand to take. I'm not saying it's easy to do, it's easy to take. Probably see that remaining for a long time. If we do not trust the authorities who are these things, or who are trying to roll out the regimes, it is difficult to probably find new ways. That is through global organizations or non-profits or a combination. I think that depends.
You
on
just
where you
mentioned
are.
literacy. There's one of the thing is that a lot of taboos in those cultures, even in India, in small villages, the other places you go, they don't trust people from outsiders. How do you overcome that process when you are implementing these vaccines and or any healthcare initiatives?
We work with local
Yeah.
partners. So our part is around the world, and then we try to figure out, okay, where is the readiness to work with a challenge like this. Then we have who execute on the ground, And our part is to build a sustainability on a 1, 2, 3 year process, and then hopefully go to the next place and scale in the next place. But it has to be locally embedded. You cannot just come helicopter and think that you can mastermind something. It has to be built
It
in.
has been. The another thing is I want to tell you, you're the world traveler. You know that the African continent, in the Rwanda, in the country of Rwanda, Thailand, the coverage of insurance is dramatically improved. It's better than in the United States. What is that fascinating thing to me? How that after going through a civil war and a genocide in Rwanda, and they came back with a force in the healthcare system. Tell us that's a great story to tell in the world, and Thailand and other Peru, these countries. Can you tell us a little bit about the country that particularly Rwanda, how they in African country after the genocide came back with a force in the healthcare system?
Yeah, so I'm not an expert on Rwanda, but what I can observe what they have done, and you cannot of fast march forward without really wanting to do it.
Yes.
And likely, and now I'm just saying likely this is based on that you needed to restart the country in a certain way, and also to build resilience in the country. And I can also say that, just jumping from Rwanda to my own reasoning for most important societal pillar, it is also based on that if we want equity, it doesn't come because we make a law in the parliament or in both houses and then get it through. That doesn't make equity. Equity is something that you need to build from the bottom up and through the whole lifespan of people by giving equal chances, but also helping those who need a bit more, and having that compassion and solidarity in a society as a by design thinking. It also requires that you put in dignity as a core principle. Dignity that you respect those, no matter which handicaps or needs they may have, but it also requires that those who are stronger do lift a little bit more. That's what solidarity is about. And look at countries who are getting this right, which, for instance, so Denmark, Finland, Sweden, and Norway, and Iceland. You get more stable and more predictable societies with this, and everybody wins. You have very few super rich, but you have many who are okay, well off.
Yeah, I lost you a little bit. Can you hear me?
Yes, I can hear you.
Yeah.
I'm saying,
Yeah, yeah. Go ahead. Yeah, I got that. You saying that resetting beautifully, eloquently said, resetting sometimes could help. Even that United States need that probably. Think that countries like Rwanda achieved such a 90% of the healthcare system coverage. We need to learn from them. That is a sad story here, but the resetting is maybe.
but
Go ahead.
but I think the to me the learning from Rwanda is a bold decision, and it's likely also based on economic intelligence, because what we see in the Western world is that we are spending huge amount of money on disease burdens which should not have appeared. And if you want to be economically wise, you could even say, if you are wise, overarching capitalistic in your approach, you should solve the problems at a much earlier stage. You can use these resources for other development of the society, which makes everybody well off. And we cannot afford this way that we build the sick care system. At some point, it breaks down. And here the Rwanda example and the Thailand examples are very good. Okay, we have to go for the primary care. We can't care. We cannot afford it. If we want to be fair to our citizens, this is where we start.
Oh, that's economic intelligence. He said that that's a beautiful word in my view. Very well used, that economic intelligence. Let us talk about the second biggest disease and the biggest number one disease is cardiovascular disease in the world. And then what is the your experience in all these Latin countries that you worked with, particularly Peru and then other countries that you worked with? Tell us a little bit about cardiovascular disease. How do you handle that? And how do you prevent and then treat this cardiovascular is the number one disease in the world. It is becoming as you said, the 90% in 2050, 90% of the people are going to have a cardiovascular disease. They said that you mentioned. It is a really staggering number. Tell us a little bit about that cardiovascular. What we need to do, and all these countries should,
Yeah.
including United States, should learn from this.
Cardiovascular is a big challenge in most countries. In Latin America, it's very big, like in US. How can I say, changed nutrition. And when you very unhealthy diet, your risk for cardiovascular is very big. Often manifested in diabetes. First goes into your cardiovascular health as well. And a part of what we have focused on is how do you then make a better patient journeys early, catch early. Well, is can still have and with a high quality of life. Badly managed diabetes is much more problematic, with ending up with blindness and amputation and dialysis and those parts. What we don't work on, but what also need to happen, is that other frames needs to change what it is or how we live, especially to more accessible for the population, especially for our children. But that's not what we focus on, but what.
Let us talk about the next big disease is the cancer. The around the world is growing cancer, and how do the countries are equipped to deal with this cancer onslaught is going to be coming to young is more and more younger people are getting affected. So it is a biggest challenge to the World Health Organizations, World Health itself. So the cancer. Tell us a little bit about that. How do you deal with this? Low income and middle income countries.
Yeah, our focus now has been on the screening more, and then also beginning to work with the disease journey in acting earlier and more precise and faster. And yes, there is a huge challenge of the cancer growth in it. Cancer and cardiovascular, large extent the same reasons, root causes. So those needs to be dealt with in other places. But what you, for instance, if you do cervical and breast cancer, it's not that complex to do. The complexity is to get people to take them. Is that the earlier you, the higher impact you have of the treatment, but the treatment is also much, much cheaper, which means that you can help if you are very strategical on. So you need to think thoroughly, how do you do smart screening and catching early. So that is the part that we are doing now.
I was talking with one of the Latin American doctors. He said that we have biggest challenges, cyclotrons in radioisotopes in the cancer treatment. He was telling about that. It is a true in everywhere in the world, actually, all the low-income and middle-income countries. Let us talk about the, first point of contact in these countries, like India, even in South America, Latin America. Pharmacies are the first point of contact. So how do you my it is my understanding, as I was during the pandemic, what I realized is that is we can implement the digital health through pharmacies, through the first point of contact like village doctors. So you're doing a very major work in the digital health side. Tell us a little bit about that, Mr. Ellison.
Yes. I let me first say I agree with you that our first point of contact being digital, be in your own community, and if that's a pharmacy, be a health community center or something else that can be us, is not that important. Give you one example on what we're doing in Ghana. In Ghana, you have a big challenge with hypertension. And then we looked at this with a local partner that we have in Ghana. So in Ghana, you have offices under the ministry, like an agency, and then you have, like in most countries, you have pharmacies that are private actors in it. So here we have done what we call digital bridges. So how can you improve a service, help a challenge without new buildings, without new equipment, with doing new ways of working? So a QR code in a pharmacy on the wall, the person scans the QR code, a staff from the pharmacy threshold, and if it's over the threshold, you get automatically referred to a hospital or a clinic. So you use what exists, no use what exists, not even new stuff. You use what's already there, but you solve for society, and you can get people caught early that have cardiovascular challenges with high blood pressure or hypertension. So this is what exemplifies what you were saying. How do you use what is already there?
You're, one of the thing is that, I grew up in a small village in India. I see that this is one of the things is that I love to see that we empower with the digital health. You're a strong proponent of digital health. You like blood pressure, vital signs monitoring, and everything. Why don't can you give these kind of things to these village doctors, a small GP, or even pharmacist? These digital health equipment devices to measure them, then upload it to the world, and then see we can empower these village doctors or village pharmacists to give a better health care to the rest of the population, because you can see on the digitally on the platform, and the people from the United States, volunteers or other organizations can give a great advice. So you're a strong proponent of health, the digital health. Does
Yeah,
it is the right direction to go?
yeah,
Giving a let's say, tell us a little bit, if you don't mind.
yeah. So I am co-chairing a actually the first ever public-private work group inside WHO, where the group that I co-chair is on out-of-hospital digital care, so home and community digital health. There are a couple of learnings from how we have applied the digital health that we need to really think about. So we have applied digital and data to analyze. That is not going to help us. We need to rethink what it is you can do with digital, and you can do it with it. You can easier for GPs, but every not even have a doctor. They might have, or they might have a social worker. So how equip these people that you have, and you just need to accept that the world. So you have the people that you have. How can you equip them, the village or the small city health, in different ways with tools? And this is possible to a large extent with digital tools, where you also can have a connected back office that then can help where you need a concrete doctor advice, so a kind of a extended telemedicine back office in that way. And this already exists. It's more, how do you challenge we have to realize it is that when you get a license to operate as a health professional, it's only for your jurisdiction, right? So when you want to do a back office, let's say from the US to Peru, to the mountains in Peru, or from Denmark to Nepal, there is a huge challenge with that you do not have the license to operate in that way. Is this a fair bottleneck to have? No. So that's one of the things that we need to solve. Do I think that that this will be a next frontier? Yes. One of the things that I'm trying to push in Latin America, I believe, is a place where we might see the paradigm shift. Is that we have a big country, Brazil, with around 300 million people, with one, and then we have a bit more than 500 million across Latin America, which means that you can begin to work with a one language interface and similar on countries from Mexico to Chile and Argentina all the way through, which means that you can probably scale things in ways that we haven't really seen before, but focusing on primary care. These countries' decision makers are actually focusing on primary care because they don't have the funding to go for unnecessarily, how can I say, expensive structures where you don't solve the things in the place. This doesn't mean that we should not have very specialized care and hospitals. We also need to invest heavily in resolving the things. Example of that, these are not only my words, is that the Danish government, after 15 years of really focusing on super hospitals, now has admitted that you need to move things back to the society to solve things. So this is a realization that is being applied now. It was decided like a month ago on it. So but I do see that Denmark is too small to really make the huge difference here. But if you push this in one language model, so both language model as the language Spanish, but also language models as AI in different ways, then you can begin the remote areas in Latin America and have that push primary care approach to help.
So, human body is a very biologically complex body, and then we don't have the data that is required, data intelligence you talk about, that we don't have enough data from all over the world. So we can come back with a proper diagnosis, not only just we can get an overall population health, we can get a better assessment of the human health itself. We don't have the data coming from, if it's not a digital health. It is important to have a digital health because we can collect this data from all over the world, so that we can get some kind of assessment what's going on with the just overall human health. Sir, can I get a take on that point with you? You are very good at that, the digital health and human health, and then
Well,
information.
yeah. So this is a bigger question, which requires changes on levels. I think there are ways to think about this. So right now, I'm Global Health Technology Assessment Conference, where you really are trying to focus in order to apply the best health value for it. What has happened over the later years, and which is also admitted by everybody, you are focusing too much on very expensive new treatments that are coming and not about what really moves the money a bit, so you can keep people healthy. And to work with big data in order to get better understanding of patterns, we part of that being applied in the European Union now, secondary data, or use of data, that helps a part of it. But if you want to work with data this way, you would need to have mutual access to data points in different ways, which probably also means that you need to abolish the concept of ownership of data, because what really provides value is when we have multiple usage of the same data points. So the business needs to change from being paid for hosting data to actually providing value to data. We really figured out what that model is to that. So our challenge today with what we dream about in health and with health data is not technology. It's the concepts and the methodology on how to work that we need to focus on, the technology in those parts. Good. I would need to leave for another meeting.
Yeah, that's I know.
Yeah,
I agree
yeah.
with you. Just the last few words and about
Yeah,
the movement.
yeah,
Thank you
yeah.
for the last question. Last words is about movement health. A little bit public-private partnership. Give us the last word, and then we'll.
Yeah.
Thank you for.
So movement health was established to solve the issues firstly in Latin America, to that the health systems are not strong enough and not really developing, and really looking at public, private, philanthropic, but also private, but in a reasonable, feasible, also ethical, dignified way, to be a part of improving this. So for the population, but also that if you want to have a functional health system, there are things that corporations are a part of. So medicine is one thing, but it's also having the scanners, providing the service. So there is a business component to having a strong and resilient health system. But most of all, for us, what the question, if we want to provide universal health coverage, to wait for the public sector to America, that would at least take 50 years. So how can we do this faster? And who are the players we should have in? And here we are trying to have a very diverse approach. We started now with having which is on the medtech, Microsoft, which is on the data, Roche, which is on pharma products, and now we are expanding to also wanting to have, for instance, logistics, but also nutrition and others in, so we get a whole ecosystem that can work with, but always work with the community, not push things on the communities, but with the communities, and with that brilliant and also prosperity for the populations.
Well, one more quick question is, I'm from Silicon Valley. What Silicon Valley can do for this overall global health? What is their role, you think, in the Silicon Valley? I'm in the middle of Silicon Valley. So tell us a little bit, that, and after that, thank you for your time. Yeah.
So I to come to terms with that. There's a huge value in applying sensible use of data and digital functions, but they also need to be adapted to the reality of countries. So, for instance, if you want to apply AI models in a lower middle income country, you need to figure out if the frames are there, the reference data to actually work with that population. If you want to go in and have information assistance for decisions in different ways on diseases. So I would actually, I'm not just asking to Silicon Valley, but to all business community. When we look at health today, the health 10% richest in the world, how can we make the business model and then come work with us?
Thank you so much. It is a truly honor to talk with you, taking your busy time. It is a very educational information you have provided. I hope you better join next time. If you join with Denmark from Copenhagen, is a better internet. We can see good video there. It's a totally an honor and privilege to talk with you, sir.
Thank you. Thank you so much. Thank you.
Thank you. Good night, by all of you. Good night.
Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it